We also looked at buccolingual thickness, as David alluded to. We use calipers in this situation. We know Ronnie Young's work relates to abutment because contour change and tissue thickness may have a correlation, but may not. I showed a case last night to David at 1 in the morning, and I said, we don't know. We don't know. We should clearly need to look at that. But again, in the study, we looked at those 3 zones. I'm glad that Barry talked about that tissue thickness, which I'll mention what Barry did. We'll try to take some of what Barry talked about. He did such a brilliant job. Barry, brilliant. Where's Barry? See here? You're just great. And as David said, don't forget, we're measuring the unsupported tissue in a buccolingual direction. That's really the key factor. Again, here, if you do nothing versus then, obviously, their best group putting the bone graft and provisional, notice these numbers, right? Doing nothing is the white. Doing the bone graft and the provisional is in pink. And you can clearly see that's a pretty good gain. Again, the 2 millimeter mark is from Ronnie Young's work. We know that that is the magic number for masking an abutment colored material. And what's that number? 0.5 millimeter. It's 0.5 millimeter. Again, if we looked at a bleeding versus no bleeding in the group that just had the provisional, again, the 2 millimeter mark is the critical. What's the range? 0.5 to 1 millimeter. If we get adherence, because that maybe is suggesting early on, if we're getting adherence, is it helping the tissue to be preserved? Really, that's the key 2 words that we talked about, tissue preservation. And again, with the bone graft and provisional group, again, what's the numbers if we got adherence? 0.5 to 1 millimeter. These are not hard numbers. When you walk out of here, all I want you to remember is 2 things. 0.5 to 1. 0.5 to 1. It's really not a very difficult number. So like I said, adherence and bleeding, the gain would be 0.5 to 1 millimeter in the thickness of the supra-implant tissue. So what that actually is alluding to is the following. That you're actually thickening your tissue without putting a connective tissue graft in. That's what that means. That's a really important concept to understand. But like I said, what's the frequency of adherence? 2/3. It's not predictable. That's the problem. And I think that's a really important message. So David, please tell us what's going on.
I mean, I got to tell you, I'm not sure. But this is what we surmise when we look through this process. I mean, what role does this immediate abutment of some sort, either the temporary or the immediate abutment, particularly something like the balance abutment as compared to a straight-sided parallel-walled abutment do? And our idea is it forms, I'm just pushed backwards, it forms an actual mechanical support. A mechanical support for a multitude of things. The soft tissue adheres to it. We have been putting in particular bone graft. That particular bone graft is going into the gap, but it's also going supra-gap, supracrestally, and gets incorporated into the soft tissue. It forms a scaffolding for that soft tissue, and if you now have adherence, you protect that from coming out. If you have just a straight-walled, parallel-sided abutment, it's going to come out. So the best thing, a provisional that, as Dr. Piatelli alluded to, something that you will get adherence to, because that seals that compartment that Dr. Gallucci was talking about. You seal it off when? During that critical phase of healing until everything gets incorporated, matures, and ultimately gets a stratified squamous epithelium growing down the side, keeping it all in. That's where the thickness seems to come from.
Again, if we just do nothing, we just put the healing abutment on and things collapse. This is at 3 months. At 6 months, when we go back with the provisional to try to stretch the tissue again, and after final restoration at 1 year, it's clearly collapsed. But the question that I posed to David last night is the following. What is the critical time frame between the time that it collapses to when you can retrieve the loss of tissue, right, Anastasia? before you can retrieve that tissue. Because there's a certain point of where you have maybe potential to get it, you fall off the cliff, you lose it, and you can never get it back. We don't know. That's, I think, a very, very interesting thing. And the other thing, as David alluded to, is what is it actually doing? It could be containing the clot and the bone graft material, which I think is very important. As Paul Weigel says, it's the prosthetic socket seal. David alluded to that. I mean, what is really going on, David, with that?
I mean, you know that area fills with blood clot, not unlike when we put an immediate implant in, and you've all seen, you know, the various animations. Blood fills the environment between the bone and the implant. You get fibrin, which is the connecting element, and that fibrin facilitates the cells coming in and maintains it, and then progressively shrinks and maintains. And you can almost see it in that early picture.
If you put the bone graft in, as Rouger's paper was already alluded to, is that potentially, you know, you could have particles that and get incorporated to tissue. Like David said, it's the clot, but some of those particles are getting pushed into the tissue. If you quote one of my good friends, Steve Wallace, Steve would probably say, well, you know, show me more. This is an N of 1 on a dog, you know, of an N of 1. We need to obviously see more, but again, in this paper it says, well, there's no inflammation around that particle, and we see it also with our patients. You know, you put a bone graft in, it gets incorporated into the tissue profile, and it physically can support it, but it's also maybe acting as a matrix so that the blood clot can organize and heal. So that's a really critical factor. Again, this is just an example where we put the xenograft in. This is Biowas collagen. Dennis and I are playing with that a little bit. 5 months, I go back, I remove the provisional. You could see here, and again, the tissue profile. So again, you know, this is something that we are looking at, but again, we don't know what's the best material to use and why. And these are still open-ended questions, which really leads us to the last piece before we go on to the last, and I'll try to cover this real quick because I know Barry covered this before. Tissue discoloration is a multifactorial problem. It could be related to implant position. We know Stephen Chen's work. Implant diameter being a factor. A wide diameter could also be like placing an implant too far to the buccal. The perineal phenotype, as we all know from Humley Wave's work. Buccolingual collapse, which we're talking about as it relates to soft tissue thickness. It's multifactorial. It's not a slam dunk. Again, one of the problems that we have with discerning tissue discoloration is the following. We seem to be able to see yellows better than we are able, we're able to see sort of pinkish colors better than we are to see yellows. Yellows would really be related to tooth color. And this is an achromaticity diagram that physiologically shows how we see color. Notice more constricted in that yellow range. Well, that's tooth color. Notice it expands further out in the pink. And if I just take this dot matrix real quick and I sort of put them in the yellow-green colors, you can clearly see here that you may have trouble reading that number. Now, we're able to see pinks and reds much better. Well, what's the color of gingiva? Pink and red. So we as human beings are more sensitized to seeing those colors. The only problem is we don't have those thresholds of perceptions for pink. We only have it for white. But we're involved in a color organization that's trying to look at that, and I know that David and Dennis and Ron Nevins and Maurice will be speaking that in the future, and Henry. So these are some of the issues that we have. We're able to see pinks and reds better, and you can clearly see with that number 8. If you can see it, I suggest you go to the eye doctor right away because you could be colorblind, and that's not a joke. Now, some of the criteria that we have presently, we need to do more because some of these criteria, in my personal opinion, is somewhat subjective. So we need to have a little bit more objective parameters. But again, it's the best thing we have right now. And again, we can use some of these spectrophotometers. A real quick summary is the following. With the spectrophotometer, we can actually compare gingival tissues. If you notice here with the line, we can actually compare the differences in gingival tissues. So we can actually try to quantify that. And with that, we can also look at what we call delta L values, which is basically telling you, is the tissue getting lighter or darker? It's pretty straightforward. We have the ability to not only look at white, but also tissue color differentiations with pink. So we look at these numbers. What do these numbers actually mean? Well, a delta L of 0 is a perfect match. You could also have a positive delta L number, which means that the tissue is getting lighter, and you could have a negative delta L, which means the tissue is getting darker. And the visual threshold seems to be a number of 2. So you have to sort of see that David said, well, you know, if you go beyond the threshold, I don't care if the tissue is getting lighter. The key is what? Tissue color matching. You want to match the tissue perfectly. So if it gets darker or lighter and it doesn't match, that's like David told me yesterday, well, it's like a crown of A1 and the next one next to it is A3. It doesn't match. So the key factor, which I thought was a brilliant observation, is really about that. Again, what about buccolingual change? If we go back to buccolingual change with the dual zone and tissue discoloration, in our study, we had 2 patients that had tissue discoloration. I want to be totally honest with you. It was one of the groups was obviously doing nothing, and one of the groups was doing a bone graft. The mistake was not containing the bone graft. It all fell out. And when it fell out, it collapsed. And when it collapsed, it discolored. You know, you sort of learn by mistakes. The percentage rate we could probably reduce if we understood that a little bit better. And again, if we put the bone graft and the provisional in, out of 17, we didn't have any discoloration. But like David had said before, don't forget, that color change could be lighter. Actually, in this particular patient, the patient actually had a lighter color change. If you look at the delta L value, it's 2.7. It may not be that perceptible. We don't know that yet. We still have to do some more of those studies. But as David said, we want to have a match. That's the key element. And clearly, it's an exciting time because there's a lot of new information that needs to be done. What about the current knowledge? We know with current knowledge as far as with platform shifting, just to go quickly through this, I think it was covered really well, is the following, is that if you have a non-platform switched implant, which was the study that we actually looked at, well, we know that we have this horizontal ring that's in red. But if we go to a platform switched implant, that horizontal biologic width could potentially be reduced. So you could see here, those studies were done by the Bohr group in South America with Dennis and Tarnow, and they showed that the other things, and also with Steve Wallace and Sang-Chun Cho. So they know a lot about horizontal biologic width. We clearly understand the 3 dimensions of that. And you can clearly see here the following, is that when you have a non-platform switched implant versus an aggressively platform switched implant going to the ankylose on the far right, it's classic. You see that amount of bone up high radiographically. We know from Canullo's study that with increasing platform shifting that you seem to preserve tissue. You seem to preserve it over time. This was a 33-month study, but again, a lot of these studies are radiographic studies. Now, the question becomes, if we have a platform switched implant and we go to an aggressive platform switched implant, could we be potentially decreasing that zone? And it's a multifactorial issue. In this situation, you can get desaucerization, as seen over here. You know, it's classic. These are from Paul Weigel's work looking at saucerization.
Watch this area over here. And realize that as this is happening, you've got a wide zone of bone that's still maintaining the soft tissue. As Henry has always pointed out, if this zone is only 2 millimeters wide and you get the saucerization, this top part of the implant is going to be very, very visible. The big advantage as we go on to platform switching is you get effectively the same saucerization, but it starts at this point, and you are now getting lateral movement along the top of the implant until you encounter the bone. So your saucerization doesn't really take place in the bone, or it's minimized in the bone depending on the amount of platform switching. So don't all get excited. It's also a platform switched implant. Platform switching is really a way, in most situations, of compensating for an inadequate connection. That's what platform switching does. You have an inadequate connection that doesn't seal, that pumps. We know it's going to cause deleterious effects. So you say, knowing that, what can I do to compensate? If you have a system that doesn't do that, meaning it's much more stable, it doesn't have the pumping, it has a long hermetically sealed connection, do we actually need platform switching? Is platform switching just a way out?
And this is just from Kisan Tan's work, where he actually sectioned them, and he's doing a lot of work with my old biomaterials professor in Seattle, Jack Nichols. And you can clearly see titanium and zirconia. Look at that fit. Barry Hoffman had given me these images over here. I know Marcus Aboud also talks about that, and you can clearly see that's the interface between the prosthetic component and the implant. Again, a popular system, the Straumann level implant, bone level implant, you can see how they sectioned it. And you can clearly see they don't all fit the same. Not all the connections are the same. You know, is it Morse taper, the number of degree? A conical connection doesn't mean it's a Morse taper connection. And I learned that from, again...
It's, again, the depth
Barry.
of this connection. It doesn't only connect and seal there, but it does it along a long length. That gives you length, which seals better, but it also gives you increased stability.
And the degree of taper,
which this
the
doesn't
interface.
give you.
Yeah, so you can clearly see here with zirconia and titanium. These are just sectioned from Kisan Tan's work. If you can play the video, again, micromotion may be one of the key factors. If there's no micromotion, Dr. Piatelli was talking about that. Barry was talking. It was just a great morning today about that. And again, the consequences could be the following. Say that you make a mistake. Herman showed beautiful placement of implants. But not everybody is placing implants ideally. The key factor is if you're placing the implant too far to the buccal, well, this could maybe work to your advantage because you won't lose that buccal bone crest, as David alluded to. Versus a non-platform switched implant, you make that mistake and you drive it too far to the buccal, you'll lose the buccal plate, and that's a factor. Again, we have to think differently based upon design. How do we place these implants 3D? Actually, ankylose, the protocol is really more in the middle because of that advantage. And anesthesia, we put this in anesthesia because I know, you didn't, you wanted to talk a little bit more about this, but one of the key factors is the following, is that the contamination of this implant design, this is a tri-lobe implant design, that with AA and P. gingivalis, that 9 out of 10 sites had contamination. But with the ankylose, only 30%, 3 out of 10 for AA and 0 for P. gingivalis. Contamination, as Herman said, it may be always there. The key factor, though, is, as David wants to talk about, is pumping. Is that bacteria pumping? And talking to Jörg Nanoff, again, the research group from Germany, it's not about the contamination, it's the pumping of pushing that bacteria out into the environment. That's a key factor. So, again, with the disconnection, you could clearly see here that non-platform switched implants, if you also talk about the vertical component that can potentially occur, that with now, say, aggressive platform switch design, a bone level, multiple disconnections may not be such a factor. We don't know how many times it can be removed. And again, a recent paper from a group that I know in Barcelona, the Barcelona Osseointegration Research Group, the BORG group, working with Dennis Tarnow, it's submitted, and what they're basically finding is some of the information that maybe it's up to 2 times. And it's a radiographic study. And they're saying that even at 4 times with the platform switching, that you only lose about a 1/4 millimeter horizontal and vertical. And, a 1/4 millimeter on a radiographic study could be within the experimental error of measurement. So with platform switching, and again, Dr. Piatelli showed gorgeous histology. I mean, it may not be a factor. The key factor may be, do you get attachment to the abutment during the early healing phase, when you need healing? But after it heals, does it matter? After the tissue's matured, does it really matter? And that is a very important point to distinguish. So again, that's something to think about. As David alluded to before, his question, which is a great question, is about the amount of platform switch.
You need a dimension. It's adequate. Platform switching, again, is not the issue. It's how much of a dimension do you have to intervene between the bacteria and direct contact with the bone. The larger, obviously, seems to be the better.
But again, we don't know what that is. And as David said, with the ankylosing system, it's 2.5 a prosthetic interface, but we have increasing amounts of platform switch from A, B, C to D. It's D being 7 millimeters wide. And you can see that that's, even at the A, which is 3.5, well, you have a total 1 millimeter platform shift, but a half millimeter on either side. That's pretty aggressive, even with the smallest diameter implant. Goes up to 1 millimeter on either side at the B, 1.5 on the C, and 2.25. And that was David's real question. What is the optimal amount of platform switch? And I'm glad that Herman's actually looking at that for bone and soft tissue preservation. That's the key factor. And again, with soft tissue thickness, again, does the design make a difference? I know that Barry covered that quite well. But Barry, please let me indulge myself because I like to look at numbers. I'm Asian. I don't know if Hamli has the same problem as I do, but we like to look at numbers, stuff like that. The bottom line is, in all truthfulness, is the following. The clinical reality is that we were never, ever able to achieve the number above 2 millimeters in thickness at the coronal 1/3 of the interface that potentially you would place your restorative margin. That's the reality. The reality is we were never, ever able to make that 2 millimeter mark looking at non-platform switched implants. So even though I told you you had a gain, I didn't tell you where you got it. You got half the 1 millimeter gain where? At the gingival and middle. You showed beautifully how to use the cementation technique, which is great, published in JPD. But the key factor is that for some of us who are shy and we're not able to clean up the cement, maybe that's the zone of where we would want to place it. Now, if I look at this example, we did everything wrong in this situation. We put the ankylose too far to the palate. There's a point, I think, where you go too far to the palate. We put a bone graft in, and we didn't contain it properly. We used, instead of a wide profile abutment or gingival sculpting abutment, we actually used a low profile one. We did everything wrong. So we wanted to support that. Even with that, losing the graft, look how thick that tissue is. And if I measure that tissue, again, Barry, indulge me, this is the numbers. The gingival, middle, and incisal. Look at the incisal. We're now over 2 millimeters. The gingival is 3, the middle is 2, but the incisal, and we did everything wrong. We did everything wrong. I got to be honest with you. We did everything wrong. It's a learning curve. I actually went out to Germany. Thank you, Jorgen, for hosting us out in Germany, because I wanted to learn how to use the system the right way. And it's definitely a different learning curve. And if we look at the few numbers, Maurice, you owe me some numbers. Where's Maurice? Is Maurice here? Maurice is not here? What a shame. Henry, it's only you? Okay. The bottom line is that we need those numbers. Because if you look at just the limited numbers, as Barry had said, Barry, let's quantify it. The bottom line is that now the 0.5 millimeter gain is not only applicable to all regions, it's applicable to the coronal 1 millimeter. And that is a big deal. That's a big deal. Again, the question, David said, well, maybe we shouldn't pose this question, but we put it back in because I know so many people are talking about that. And the question that I had for Barry is the following. Barry, in a non-platform switched implant versus a platform switched implant, what is the maximum soft tissue jumping distance without losing buccolingual contour? What is that? What's the maximum soft tissue jumping distance? Because now we have to think. You showed slides like this, non-platform switched and the ankylose. I have slides like that too. I want to know, what is the jumping distance? Isn't it a great time to practice dentistry? How much research we need to do? Hopefully I've given you a lot of ideas that we could either collaborate and work together to try to find some of these answers. And as far as the last piece, what about tissue discoloration? We don't know. How do we correlate all this information? So that's something that's up for grabs. And I just want to have this clinical example, and we'll finish up real quick. One example that David had done.
Let's go back onto that. This is a very typical type 1 site, meaning it's one of those very few where you have no labial loss of bone. You can see it's an external resorption case. No loss of the interproximal height of bone, so you know those papillae are going to be there. It is a thick biotype. How many are thick biotypes? way less than 10%. It has thick tissue, it has thick bone. It means you can really approach this completely differently to what you would have to do traditionally. So in this case, you could do it flapless if you want to. We don't, for the most part, in Atlanta, suggest to do it flapless because we invariably have to introduce connective tissue. Once I'm introducing connective tissue, we're raising mini-tunnel vertical flaps. We want an implant with micro roughness, as Dr. Piatelli said, all the way to the interface of the abutment. We want to place it subcrestally so that we will maintain the bone all the way up to that rough surface at least. And then you would like a bacteria-proof connection. You want a bacteria-proof connection so that the bacteria don't go out, and you want a stable connection so that if there are bacteria, which there are going to be, they don't get pumped out. So platform switching is now, if all this fails, I'd like to have platform switching as well. That's what I'd like. One abutment, one time is really a term we utilized in the early days when we didn't have this kind of stability. And the question then becomes, is 2 times, as Abramson said, the magic number, or could you actually squeeze it to 3? But let's not do it indefinitely.
But the one abutment, one time may have the most clinical biologic significance during the initial healing phase.
So again, you can access this article where we broke this up into 4 different categories, depending on what the parameters were. And you can see this is really a type 1, this one up here. You can do an immediate without flap reflection and get optimal results because you've got thick tissue, thick bone, you can do it flapless. It's one of those few cases that you can do it. Going through this implant version of it, optimized placement, I think more and more we will do this because we can optimize it for the restorative as well as for the surrounding soft tissue that contains it and bone. So we frontally optimally position it, mesiodistally, you sagittally position it, tending it towards the lingual but overdo it. You don't want to cantilever this too aggressively forward, but don't indulge the buccal plate.
And it can give you some flexibility because of the limited micromotional things we talked about, that, you know, placing in the middle is not a negative thing and with their design.
We graft the gap. We graft the gap always. There's no reason not to graft it. We know you may get osseointegration, but from an aesthetic perspective, we graft the gap routinely. Always. As Henry would describe this, avoid stressing the labial plate. That means don't even look at it. Stay away from it. You don't want to compromise it because that's the collapse that we're talking about. We graft extraction sites, whether you place the implant or not. It always gets grafted. We tend to like, based on the literature right now, long-standing grafts so that you get long-term scaffolding. In the old days, you wanted rapid turnover. We don't want turnover. We want it just to be there, to be incorporated and stay there until kingdom come, literally. You want a minimum of 2 millimeters of soft tissue thickness to disguise the potential of underlying color coming through. Where do you want it? You want it right at the very tip, up here. Remember, down there doesn't help me much. It's really where the restorative part is, over there. That becomes much, much more critical. From our perspective, anytime you raise a flap, put a connective tissue graft of some sort. You can use some of the aloe, you can use pericardium, but you should do that. Given our options, find a system where you can use one abutment one time, because that way you do get an effective seal. It may be that you can do better than that and go a couple of times. Big thing is, don't touch the labial plate. turn over. This is the system. You can see the histology from Paolo Trissi with the bone going over. This is the typical radiograph that you would see. And this is the, do these play or not? I don't think so.
We have to probably finish up.
So we won't play you those. Again, long term, look at the thickness of the tissue even compared to the adjacent two teeth as we go through it. And then longer term healing. Adjacent crowns, this one matches the soft tissues, blend in. There's no real change in form at all. This is part of the study as we went through it, how we went through the measuring process. And just play this video and we'll finish on it, just to show you what that tissue looks like. James, can you play that one? This one here. There you go. So you have one of the balance abutments. We unscrew it. And what you want to look at is the tissue as we unscrew it and pull it out. You see it's a two-piece. The screw obviously comes out very easily. This part doesn't come out for two reasons. One, because it adheres, and two, obviously there's a certain degree of suction. As we try and zoom in on this area, you will see that you have epithelium keratinized. As it goes down into this effective sulcus, it remains keratinized. As it turns the corner, then it becomes non-keratinized. And then you can see the bleeding where you have adherence lower down. So the coronal portion, look how it's actually keratinized, then becomes non-keratinized. You can see the capillary loops in it. Then you get to the area that's actually effectively torn, we believe, that first time.
And that initial phase of healing may be the most critical where you're getting the attachment. After it matures, like Herman said, maybe it doesn't matter.
It may not matter.
It might not matter. Just the last segment, I just want to make just a certain statement about this is the following. The future with the acquisition of Astra is the following. They have the ability to now go back to what we used to do before, the work with Dennis, Sanction Show, Steve Wallace, about inter-implant distance. The critical factor to understand is that between implants, the biologic width is subcrestal. Now with the newer designs, it could be equicrestal. The key factor that David talked about is really supracrestal biologic width. That's a really important concept. What we do is we erupt teeth in compensation in an effort to obviously regrow tissue. We know that from Team Atlanta's work. Over-extruding the papilla. Over-extruding the papilla so that when we place implants in, multiple implants is really the segue into things, is the following. Is that we know we're going to get dieback of tissue, but we've overcompensated through forced eruption. So again, we have a shorter papilla, as seen over here, but they're pretty equal. Two central incisor implants. Now, the question with the acquisition of Astra is the following. We're almost back to the good old days. And the good old days is that we were working with scalloped implants. I was working with scalloped implants a long time ago. And this acquisition is huge because we're now thinking about supracrestal biologic width. I mean, that is a really big deal. Because in the old days, this is 10 years ago, I was making prototypes for companies that looked at scalloped implant designs. I actually made them myself because people want to go around and show the concept to these companies. And here's an example I'll show real quickly. An example of a patient. She was actually missing her 6 anterior teeth. We did guided bone. Notice she has a flat ridge. And that's a key element that will be discerned. Scalloped implant, flapless, guided surgery, scalloped implants with the different components. And I just want to cut to the chase. Cutting to the chase is the following. This is the abutments in place, and this is the case. And this is the final case with the x-rays. And I have 2 words for this case. It's bad and it's ugly. It's bad and it's ugly for the following reasons. What was lacking? Back then, 10 years ago, we didn't have all this knowledge that we have today. We didn't know anything about implant design, tissue level versus bone level implants. Don't forget, when the perfect implant came out, it was a tissue level implant. We know so much more about it. The microgap and micromotion, supracrestal biologic width and subcrestal implant placement. And it was naive and stupid of us to believe that we could take a flat ridge and put in scalloped implants and expect to get scalloped bone and tissue. The thinking is the following. You may need to scalp the bone and the tissue and have an implant that can preserve it. And clearly having an extraction site that has all the osteotomy developed for you may be the perfect segue for the new design and the new acquisition. And that is a big deal. So in summary, it's important to place an immediate abutment and provisional at the time. Clearly, yes, and hopefully you can get adherence. If we can increase that, that would be great. Is it important to place a bone graft? Sure. That's your insurance policy. That's your insurance policy. The answer is definitely yes. And is the design of the implant and abutment interface important? Clearly, I think most of you have seen that answer to be yes. It was beautifully exemplified. And can multiple anterior implants be placed in the aesthetic zone? Maybe. But maybe the two words is that we have a better opportunity to do so. And with that, David and I really thank you for the time. David helping me at the last minute with Dennis not being able to be here. But it's always been an honor and pleasure to lecture with my teacher and practice with Dennis Toronto, my partner. Thank you very much. Much appreciated.
And let Dennis know we missed him.